We're in our study of the lower extremity, and because the knee is so frequently injured, it's just way important that we know the muscle motors and some of the mechanics of the knee. And if you go into physical therapy, I know a number of you are thinking that direction, or into medicine. When it comes to orthopedic injuries in a general physical therapy clinic, or as a family practice physician, or as an athlete trainer, 40% of the orthopedic cases that you'll deal with are knees, so you need to know the knees. I think it's way important, don't know that it gets emphasized enough, that both medially and laterally, these huge features of the distal femur are the condyles. The epicondyles are the focal prominence in the frontal plane, but the big old condyle is the articular surface that interfaces with the tibial plateau, with the menisci in between. Obviously, the hyaline cartilage that we'll talk about here in a minute will be featured. And then, just because some of you, if you go into physician assistant or into medicine, orthopedics, then you're going to be a person who does joint replacements at the knees. One of our alums is a joint replacement PA specialist at UCSD, doing really good work there. So here we are in the knee. You know that the actions include flexion and extension. We're going to talk about muscle motors here in more depth. And then rotation. This athlete is in a closed kinetic chain, rotating, foot is fixed, femur is rotating on the tibia, and you've got to have constraints there, both inert capsular ligaments, the cruciate ligaments, the collateral ligaments, and dynamic stabilization of the joint through the muscles. We talk about core stabilization, we tend to think here, but in order to preserve the integrity of the knee, you have to have real, very strong accelerators, obviously, and way big important to us is the eccentric contractions that lead to breaking. Extreme positions of the knee, genu varum, where the ankles come together before the knees come together. Obviously, there's a rheumatoid arthritis that's present in this particular knee that misshapes the knee, and this crescendos into more extreme posture. Genu valgus, where there's movement away from the midline, and then genu recurvatum. You see this in conditions where people's connective tissue might be diseased, or they're predetermined genetically to have extreme postures of the joint. You know that the major joints that we're studying, including the knee, are synovial joints, and one of the features of a synovial joint is the synovial capsule, which is deep to the ligamentous capsule. Well, when there's swelling in the knee, you get an appreciation for how large volume the synovial capsule is. This is a knee with a reasonable amount of swelling, and this is like a reservoir for the synovial capsule is like a reservoir that fills up with excessive fluid, and the portions of the synovial capsule get named, and this is the suprapatellar pouch. And when you're in courses that study pathology like Intro to Athlete Training or Lower Extremity Assessment class, you'll study about the palatable patella to quantify how much swelling there is. And then the gastrocnemius bursa can get full. So when a knee is really distended with swelling, the person won't want to get into extreme extension because it places pressure through this portion of the synovial capsule, and they don't want to go in extreme flexion because pressure on the free nerve endings here. So a swollen knee resists extremes of the range of motion. And then I'm going to let you study this on your own. I think you know this about collateral ligaments and cruciate ligaments. The reason I'm featuring it here is that you can see the articulation of the patella into the trochlea. The typical patella has this convexity, and the trochlea is a concavity, and there's union here. This helps keep that patella tracking in the trochlea. And the retropatellar surface and the articular surface of the big old huge condyles and the tibial plateau are covered by hyaline cartilage, which is tissue that has high water content and a low coefficient of friction, so there's reduced friction. And again, because you're bombarded with the influence of the cruciate ligaments, I want you to appreciate that in an open chain, the anterior cruciate ligament prevents anterior riding of the tibia on the femur, but in closed chain, the way things get hurt, it's just the opposite. It prevents anterior riding of the femur on the fixed or posterior riding tibia. Now in this particular case, appreciate the fact in open chain, the way you remember it is the anterior cruciate ligament prevents anterior riding here, but in a closed chain where the tibia is fixed, it's the femur moving anteriorly that disrupts the ACL. Or the ACL also is an anti-rotational tether, and that's a means by which the cruciate ligament can become damaged. The pulley system of the patella, please note that the patella is built into the tendon, the quad tendon. That the posterior aspect of the patella, if that smooth hyaline cartilage gets disrupted, that's osteoarthritis. Now this has been surgically stimulated to get hyaline cartilage to regenerate there. And then the Q angle is formed by the two tangents, a line drawn from the ASIS to the center of the patella, and from the patella to the tibial tuberosity. The greater this angle, the more lateral tracking the patella will do, and that'll wear the patella out. Contrast that with a smaller Q angle, and the patella will track more vertically. Now, what keeps the patella from drifting medial or lateral? It is the bony contour that I just showed you. You can see it again. The retropatellar surface interfacing into the condyle. But also the fact that it's built into the tendon, and the patellar collateral ligaments, also known as the retinaculae, are tethers to prevent, watch me, this tether would prevent the patella from tracking medially. This retinaculum would keep it from tracking laterally. So the patellar collateral ligaments, also known as the patellar retinaculae. And then another emphasis on the relationship. This is the sunset view, where the x-ray is taken in this fashion, and you can see that there's a fractured patella, but it's in place. This is a luxated patella. The patella has tracked laterally, and it is now sitting on the lateral condyle. A disarticulated knee with a view into the tibial plateau. So here's the knee, femur, the tibial plateau. Well, we take the femur away and look down onto the plateau of the tibia, and you can see the semilunar cartilages. The medial is C-shaped, the lateral is more oval, and the attachments of the cruciate ligaments on the spines of the tibial plateau. Okay. All right, and then the muscles. The muscles that are muscles of extension obviously are the quads, and because these muscles pass anterior to the frontal axis, in an open chain, the tibia moves into extension on the femur. Through concentric contraction, if we're loaded up doing a squat, these extensor muscles control the rate and extent of flexion. And then the flexor muscles obviously are muscles that pass posterior to the frontal axis. The hamstring muscles, the gastroc muscles, and a vestigial muscle, little tiny muscle belly called the plantaris. This muscle is huge in the frog. But for us it's a little tiny muscle belly, and that tendon traces to the medial calcaneus. Sometimes it feathers into the Achilles tendon that is shared by the gastrocnemius and the soleus underneath. We'll study about that a little bit more. But you can imagine this muscle does not generate much force. The plantaris is called the first-year med school artery, because if you encounter it down in here and you're not aware of it, you'll go, what in the world? That's thick like an artery, not thin like a vein. That must be the tibial artery. So be forewarned before you take your gross anatomy class that this is in the deep posterior compartment and there you go, the plantaris. Doesn't have any big bearing on powerful movements, but there it is. And then the pes anserine are the three muscles, the gracilis, and the gracilis, pubis to anterior tibia, the semitendinosus from the ischial tuberosity to the anterior flare, and then the sartorius, longest muscle in the body, from the ASIS all the way lateral to the pes anserine. So pes anserine, it hurts on the medial flare of the tibia. Okay, and these muscles have an influence on knee flexion. Here are the tendons of the pes anserine. By the way, these are the slides from your PowerPoint presentation. You can go back and study. And then posterior deep is the upside down muscle, the popliteus. Appreciate the fact that in the cadaver we see the popliteal fossa. This is medially situated, and its tendon moves superiorly and under the cover of the lateral collateral ligament. When this contracts, it internally rotates around the longitudinal axis in relationship to the frontal axis. It's a flexor. Okay? The other internal rotators are semimembranosus, semitendinosus. Okay? When you put the axis of rotation here, then it will rotate the muscles internally. The only external rotator of the tibia is the biceps femoris. Just know that. And then I want to finish with a muscle that's very small and very deep. Not many people know about the genu articularis. Its responsibility is that when it contracts concentrically, it pulls the capsule into out of the way of the articulating tibia and femur and prevents capsulitis. Interesting feature, and wanted you to know about it. Bless you. Be a student of the knee.